This program is brought to you by Emory University.
We have today Dr. Parashar, who's an associate professor in cardiology, who has a unique experience of having practiced general internal medicine at Emory for 8 years prior to joining cardiology. She went to MCG in Augusta and also has a master's in public health and master's in clinical research here from Emory, followed by her cardiology fellowship. She's been very interested in women and heart disease as well as cardio-oncology. She started the program here at Emory several years ago and is going to give us a talk today on cardio-onc cases and conundrums.
Good morning, everyone. Thank you for the opportunity, Dr. Mehta and Dr. Taylor, for this opportunity, and especially Dr. Taylor for all your support during these very difficult times. So I'm going to present conundrums of cases in cardio-oncology. My first case will be based on anthracycline cardiotoxicity. So in June of 2017, a patient presented to the emergency room with shortness of breath, edema, and early satiety. She had gained 20 pounds of weight in about a month and was complaining of significant orthopnea, so much so that she was sleeping in a recliner for past month. On exam, her blood pressure and heart rate were fine. Pulse ox was 96% on room air. She had a elevated JVP to the angle of the jaw and had bilateral crepitation. Her chest X-ray showed pulmonary edema, and her BNP was extremely elevated at 3268. She also has a history of breast cancer and had received dose-dense adriamycin from January of 2016 to June of 2016. After presentation in September 2016, this is her echocardiogram, as you can see here in the left most pane, where her ejection fraction is normal. And when she presented in June 2017, her ejection fraction, as you can see on the right panels, are markedly decreased with EF of about 25–20%, severe mitral regurgitation. We sent her for a cardiac catheterization because of this acutely developed pulmonary edema and LVEF being so low. It showed normal coronaries. Thus, we made a diagnosis of non-ischemic cardiomyopathy, which was due to anthracycline cardiotoxicity. The cardiotoxic level of anthracycline in her case was her cumulative dosage of about 300 milligram per meter square. Anthracycline cardiotoxicity can present from no cardiotoxicity to all the way to the range of death. We define cardiotoxicity as a decrease in LVEF of more than 10% to the LVEF of less than 53%. So for example, if a patient had LVEF of 65% pre-chemo and now has EF of 55%, that will not be called cardiotoxicity. However, if a patient has EF of 50% or 55% pre-chemo and now it's 45%, that patient will be defined as having chemo or anthracycline-induced cardiotoxicity. It can range all the way from no cardiotoxicity to subclinical myocardial injury, asymptomatic LV dysfunction, heart failure, which this patient had, as well as refractory cardiogenic shock. Anthracycline cardiotoxicity is of 3 subtypes according to the time of onset. The acute onset, which I've seen just a few cases of, can occur after a single dose of anthracycline or a single course of anthracycline included chemotherapy. The clinical manifestations usually occur within 2 weeks. The early onset is the commonest that I have seen. It can occur up to less than 1 year after the receiving the anthracyclines. It's the commonest kind. It's a dose-dependent progressive decrease in LVEF, leading to dilated cardiomyopathy and congestive heart failure. Or it can be late onset, which can occur more than after a year, sometimes decades after anthracyclines. Anthracycline cardiotoxicity has three main features. It's dose dependent, as you can see here, with a dose of about 400 milligram per meter square of anthracycline. The incidence of heart failure, this is symptomatic heart failure, is 3 to 5%. And as the dose increases, the risk of cardiotoxicity or the incidence of heart failure increases progressively. The lowest rate of anthracycline cardiotoxicity is in liposomal anthracyclines, which is 2%. And this is the safest anthracycline to give. The drawback is that it's extremely expensive. Cardiotoxicity due to anthracyclines is irreversible. So as you can see in the electron microscopic features, the myofibrils here in the cardiac muscle are very nice. This is normal, linear. And here is all scattered, irreversibly damaged myofibrils. Same thing here, a lot very normal endoplasmic reticulum and lot of vacuolation occurring here. The other feature of that is important to recognize or to be aware of is that anthracycline heart failure has worse prognosis than idiopathic and ischemic cardiomyopathy, almost 3.5 times mortality compared to idiopathic ischemic heart failure. So you can see the slide here. The number of years is represented in the x-axis and proportion of patients surviving is in the y-axis. And you can see here is that cardiomyopathy due to doxorubicin therapy, the curve is quite steep and is worse than several other features such as peripartum cardiomyopathy, idiopathic cardiomyopathy, and ischemic heart failure. So in this patient, she had no cardiotoxicity when she received her chemotherapy from June of 2016, from January 2016 to June 2016. And then she presented in 2017 with heart failure. So what could we do? Could we have done something different with this patient? Is there any way to recognize who progresses and who doesn't? So these are the guidelines for echo surveillance during and after anthracycline and HER2 chemotherapy. Everybody who is receiving anthracycline or HER2 targeted therapy or a combination therapy should have echocardiogram at baseline. And during anthracycline therapy, echo should be done at a dose of 240 milligram per meter square, and then at each additional dose of 50 milligram per meter square. After completion, the recommendation is to perform an echocardiogram, and at 6 months, if the cumulative dose is less than 240 milligram per meter square. For HER2 targeted chemotherapy, the recommendation is to do an echocardiogram every 3 months during treatment. Same thing for combination chemotherapy every 3 months during treatment and 6 months later. There are 5 categories of patients who are at high risk of developing cardiotoxicity due to anthracyclines. Number 1 is people or patients who receive a high dose of anthracycline, which is doxorubicin more than 250 milligram per meter square. As you can see here, as the total dose of doxorubicin increases, the probability of heart failure increases over time. Patients who receive radiation therapy with heart in the field of more than 30 grays have higher risk of cardiotoxicity, as you can see here. As the mean dose of radiation increases over time, the risk of cardiotoxicity increases. If the anthracycline dosage is lower, which is 250 milligram per meter square, but they have radiation therapy in addition, even a lower dose, these patients are at higher risk of cardiotoxicity. In our patient who received anthracyclines and our HER2 therapy, that is trastuzumab, the risk was much higher. So this graph shows that the risk of our incidence of heart failure in 12,500 women of breast cancer in this retrospective had 4% risk of cardiotoxicity or incidence of heart failure. In patients who were receiving just trastuzumab, the risk was 12%. But look at this, if the patients were receiving both anthracycline and trastuzumab, the incidence of heart failure was 20%, which is 1 in 5 patients. And finally, the fifth category is if the patient has presence of cardiovascular risk factors, which is more than equal to 2 cardiovascular risk factors during and after treatment, which is diabetes, hypertension, smoking, etc. If they're of older age, which is more than 60 years, or they have compromised cardiac function, that is borderline low EF of 50 to 55%, history of MI, or valvular heart failure, and African American race. So in this lady, this is pre-chemotherapy in June 2016. I went back and looked at her echo again to see if there was any way we could have predicted that this lady would have heart failure. So this is all looking retrospectively. So in June 2016, her ejection fraction was preserved at 55%, and her global longitudinal strain in the echocardiogram was 19.7%. In March 2016, this is in the middle of her chemotherapy, her ejection fraction was still 55%, and her strain now has decreased to minus 17.2%. This is at completion of chemotherapy. Her EF was 55%, but her global longitudinal strain had decreased to minus 16.1%. So there was a decrease from 19.7 to 16.1. What does that mean? We'll come to that. This is at presentation in September 2017. As you can see here, the ejection fraction was 15%, and her global longitudinal strain was minus 5.8%, which is extremely low. So there were several studies performed for looking at pre-chemo global longitudinal strain and whether that is predictive of cardiac events. In this study, GLS of less than 17.5% was associated with a 6-fold increase in cardiac events. So this was a study in 450 hematological cancer patients who received anthracycline and were followed up for 4.2 years. 6% of these patients developed cardiac death or symptomatic heart failure. The authors found that a GLS of less than 17.5% was present in 23% of this population, population studied, and it was significantly affecting the mortality or the cardiac event survival of these patients, as you can see in this graph here. GLS also has very incremental value of predicting cardiac events. So in this patient, you can see if in this study, with the clinical variables, it's predictive of heart failure. Same thing when we look at clinical variables plus LVEF, but when you combine clinical variables, LVEF and GLS, we can predict which patient would develop congestive heart failure if they're receiving anthracyclines. This is an expert consensus for multimodality imaging evaluation. And basically, the recommendation is that to compare the global longitudinal strain of patients, and if there's a drop of more than 15%, then these patients should be monitored more carefully, and perhaps consideration of ACE inhibitors and beta blockers be made in these patients to prevent cardiotoxicity. There are several studies ongoing to evaluate this. This is not a firm recommendation, but if what I do in practice is if I see progressive decrease of GLS, and especially if there's a reason for these patients to be on ACE inhibitors or beta blockers, I start that. We'll go to case 2. This is a case of Nivolumab Cardiotoxicity. So this patient was a 47-year-old lady with refractory multiple myeloma, which was treated with off-protocol use of nivolumab, pomalidomide, and dexamethasone. She was started on radiation therapy to treat plasmacytoma of the lumbar sacral spine. Soon afterwards, she developed chest pain and fever. She had a temperature of 39.5, and her pulse ox was 89% with no signs of heart failure. a troponin level was more than 70. Interestingly, sadly, in fact, when I was reviewing the slides and I saw these, the data, it sounds like a COVID myocarditis, doesn't it, in this day and age? But this was several years ago. So we looked at her EKG and it showed ST elevation in several leads, especially lateral leads with reciprocal inferior ST depression. Because of the concern for STEMI, she was taken to the lab and she was found to have normal coronaries. Her echocardiogram showed LVEF of 30 to 35% with global hypokinesis and right ventricular dysfunction and pericardial effusion. We performed a cardiac MRI because of a very high pretest probability of myocarditis in this lady, which showed mid-wall enhancement of the interventricular septum and the inferior wall, as you can see here, which was consistent with myocarditis. These are some other pictures, images of the cardiac MRI showing increased signal in the interventricular septum, consistent with edema, which is a feature in acute myocarditis. So let's talk about what happens with acute autoimmune myocarditis with immune checkpoint inhibitors. So these are, I've listed some names here for the immune checkpoint inhibitors. Mainly the way I remember it is they end in MAB. So they are immune checkpoint inhibitors here. This is the mechanism I have listed here. Basically the T cells express PD-1 antigen here, and then their PD-L1 is expressed by the tumor cells, and these ligands or these inhibitors bind this ligand and thus let the T cells destroy the tumor cells. That's how I understand it in basic non-oncology language. Acute autoimmune myocarditis secondary to treatment with radiotherapy and immune checkpoint inhibitors is a very rare phenomenon. You can see here that this is the normal myocardial cells, and this is what happens with a lot of lymphocytic infiltration in the pathology of these myocarditis patients. The incidence is 0.06% of these myocarditis due to these checkpoint inhibitors. In these patients, the recommendation, as we saw in our patient, is to do an EKG and troponin, which was extremely elevated. And if we go down this pathway, if the EKG is abnormal and the elevated troponins are there, there's possible myocarditis, and this patient should be considered for cardio-oncology consultation. This lady had multiple episodes of ventricular tachycardia while she was in the hospital. And because we knew about this phenomenon, she received 1 milligram per kilogram of methylprednisone with immediate symptom resolution. Her troponin levels normalized over 10 days, and she was discharged home with aspirin, beta blocker, long steroid taper, and a life vest. Her echocardiogram at 4 weeks and 6 months showed improved LVEF. Unfortunately, this lady, who was actually a very favorite patient of mine, she just had amazing spirit and just was so optimistic, passed away due to the complications of the cancer, not cardiac effects. So the summary is that of this case is that myocarditis is uncommon but can be fatal. Early identification and treatment with high-dose steroids lead to uneventful outcomes in these patients. This case we actually published with the oncology team because this was very early on before the myocarditis recognition has improved. So going to case 3, this is a case of 5-FU cardiotoxicity. So I saw a patient, a delightful lady, 59-year-old with anal carcinoma. She was on continuous 5-FU, which was started on October 15, 2018. She didn't have any cardiac history and for some unclear reason had a normal cardiac catheterization in 2009, so about 9 years ago. She presented to the ER in October 2018 with severe chest pain, heaviness, chills, dyspnea, and no relieving factors. Her initial troponin was 0.09. This is a presenting EKG, and you can see here the STs are elevated and again in the lateral leads here, and some suggestion of ST elevation in these lateral leads as well. Her troponin was increased to 0.15, and she continued to have chest pain. We did a quick bedside echocardiogram that showed basal and anterolateral hypokinesis. So we diagnosed her with for lateral STEMI. She was taken urgently to the cath lab. She was found to have normal coronaries with diffuse coronary vasospasm. So our diagnosis was STEMI due to coronary vasospasm due to 5-FU. Cardio-Oncology was consulted, and we started her on amlodipine nitroglycerin with complete resolution of chest pain. She was discharged on amlodipine nitroglycerin, and when I saw her in clinic, it was very challenging to continue these medications because she was relatively hypotensive. So talking about 5-fluorouracil, these are fluoropyrimidines. It's the third most commonly used chemo for solid malignancy, including head and neck and GI cancers. And it's the second most common drug associated with cardiotoxicity after anthracycline. So very important to know about this particular drug. The symptoms are present in 0 to 34% of patients. This is a wide range due to multiple studies showing this. Patients present with chest pain, angina, ACS, atrial fibrillation, myocarditis, or pericarditis. The median time of onset is 12 hours after infusion or 1 to 2 days. It disappears quickly, the chest pain, after discontinuing the medication, or may last for several days. The risk factors are age more than 55 years, hypertension, hyperlipidemia, smoking, and prior CAD. This is a detailed mechanism for 5-FU, but basically I want you to focus on this red rectangle here. 5-FU primarily causes direct endothelial cell damage and smooth muscle dysfunction, leading to coronary vasospasm. So the interesting issue about this patient was that she did not, according to oncology, she did not have any good alternative for treatment without 5-FU. So the question I was asked is, can we re-challenge her with 5-FU without that? She already had lung meds and the mortality would be high, so what should we do? This study actually was published after we saw our patient, but I wanted to bring it here. This is a detailed flow chart for your reference, but basically the bottom line is for our patient is here. If the patient had, like we did in our patient, if the patient had chest pain, we discontinue 5-FU, put her on nitrates and calcium channel blocker, and do a cardiac angiogram like we did. And if they don't have clinically significant CAD, then avoid further 5-FU is the recommendation by these authors. In this patient, since there was no good alternative, the patient was very keen to have 5-FU. And after several discussions of risk and benefits with oncology and patient, we decided to re-challenge her with 96 hours of 5-FU continuous infusion and radiation therapy. So we prophylactically admitted her to CCU and we placed her on nitroglycerin drip and amlodipine and started her on 5-FU. She started having chest pain again on day 2 of 5-FU, which resolved in 10 minutes with increasing dose of nitroglycerin, and she required significant increases in nitroglycerin. No EKG changes were present at that time. During hour 91 of 5-FU, she started to have severe chest pain with EKG changes, looking like STEMI, and so we discontinued 5-FU at that time. She had only 5 hours of 5-FU therapy left. I'm still seeing her occasionally. She's doing great, no further complications, no cardiac complications, and she's very pleased that she was able to get 91 hours of 5-FU. This is the last case of radiation therapy induced cardiotoxicity. So in February 2018, I saw a patient, a 68-year-old male, who presented with persistent fatigue on exertion. He reported that he was unable to play his 3 times a week golf. He didn't have any cardiac history. His cardiac risk factors were hypertension, remote smoking. He had a history of Hodgkin's lymphoma and had completed R-CHOP therapy in 2007. His cumulative adriamycin dosage was 250 milligram per meter square. He had radiation to the mediastinum of 60 gray, which is very high dose. Remember, we said that more than 30 gray is a high risk factor for developing CAD. His post-treatment echocardiogram had shown normal EF. This was his echo on presentation. As you can see, his EF is markedly down. There's wall motion abnormality here and enteroseptal wall, and there's significant mitral regurgitation, probably ischemic. So we did a cardiac catheterization. As you can see here, his right coronary artery has a CTO, and also his LAD here is showing right here, complete total obstruction, chronic total obstruction. So radiation therapy increases ischemic heart disease. The risk of ischemic heart disease is proportionate to the mean dose of heart, as we've seen before in this particular slide here. It begins within first 5 years of radiation therapy and continues for at least 20 years. The pre-existing cardiac risk factors increase the risk for radiation therapy. And I wanted to show you cardiac CTA here, is that there's a lot of calcification in these patients, mainly at the ostium and branch points. The lesson that we learned in the cardio-oncology patients is that as the time and years have elapsed, the death due to cancer has been pretty stable at plateau. However, the deaths due to cardiac events have markedly increased and are continuing to increase over time. So in conclusion, accurate assessment of LVEF is essential for cancer therapy and its monitoring, and should be done with the best method available in the echo lab, ideally 3D. Global longitudinal strain is the optimal parameter of deformation for the early detection of LV systolic dysfunction in patients receiving cancer therapy. Cardiac MRI is a useful modality for diagnosis of myocarditis, which can be an unusual but potentially fatal complication of immune checkpoint inhibitors, as we saw. And radiation-induced CAD is under-recognized and is associated with high risk of morbidity and mortality. Timely diagnosis requires high degree of index of suspicion in these patients. So with this, I will end, and this is my future goal. Hopefully everything will be new normal, as Dr. Taylor said, and we can travel and visit these wonderful places. So in the meantime, let's be calm and kind and safe. Thank you so much for your attention and for being here and for giving me this opportunity. And I'll take any questions, please.
Okay, great. Thanks so much. And you can either text me your questions or type them into the chat, and I will read them aloud. I'll start off with a question. So when you get called by oncology for somebody who they're planning to start anthracycline for breast cancer, do you put them on an ACE inhibitor and beta blockers even if they don't have any cardiac dysfunction?
That's an excellent question, Dr. Mehta. Thank you for asking that. So when there have been several studies which have shown, smaller studies, but have shown that patients who are on ACE inhibitors or beta blockers pre-chemotherapy are less likely to develop congestive heart failure or cardiotoxicity. So I try to, if they call me, like actually over the weekend, they called me about a patient with oncology, whether they were going to get anthracycline too, and they were wondering what they should do because the patient had heart failure 10 years ago, but now is completely fine. So I do start in these patients on small dose of ACE inhibitors, ARB or beta blocker if the blood pressure can tolerate it. Especially the recommendation is that especially if these patients there is any reason to place them on ACE inhibitors, beta blockers or ARB, we should do that. So for example, if the patient has hypertension and is on hydrochlorothiazide or hydralazine or something else, then these patients, you can take them off take these patients off those medications and put them on ACE, ARB, or beta blocker. Especially if I start, and also the other two reasons I'm more aggressive with their treatment with ACE or beta blocker is if the strain starts to decrease, as we saw in our patient, or if they have pre-existing cardiac conditions, or if they're going to be falling in the 5 categories of patients I showed who are going to receive combination therapy or high dose of anthracycline or anthracycline with radiation therapy. Again, these are the patients I start them on ACE or beta blocker.
Okay, we have a question from Dr. Sherman. Is there any data with Entresto?
Great question. We don't have any data with Entresto right now, but that's another interesting point. I have to emphasize that once these patients develop heart failure, they should be managed just as any other heart failure. We don't have any evidence that they should be managed differently. So Entresto will be considered in these patients like other heart failure patients.
So when you describe the myocarditis with the immune checkpoint inhibitors, is it a fulminant myocarditis that's bad, that requires ICU, or is it more subtle? And I ask that because let's say you have a patient on the floor with mild troponin leak, and we're always asked the question, is it a non-STEMI or is it myocarditis, and do we treat with steroids in addition to non-STEMI treatment? Or is it pretty obvious that it's myocarditis?
That's a good question and a tough one because it's difficult. We're not going to do a cardiac MRI on every patient, unfortunately, because of the resources. But these points, I've seen both. I've seen fulminant myocarditis like we saw in this lady who had basically presented with chest pain and had just almost refractory VT that resolved when we started her on steroids. And I've seen very mild cases of myocarditis when I'm on Hearst or elsewhere when we do consultation on oncology, which is a mild case of myocarditis, very small wall motion abnormality, small leak of troponin, and the presentation is just some chest pain. In those patients, I basically discuss with oncology, if they think patient can get steroids, then we give them some steroids. Otherwise, it's just a difficult diagnosis where we're just watching the patients conservatively in the beginning, at least, in the very mild cases.
Okay, we have a question from Dr. Gongora. How do you manage high-dose steroids? And in acute myocarditis, what is the criteria that you use to decide duration of steroid treatment?
So the first question, the part is what's the dose? So 1 mg per kilogram, which was in my slide, in my slides, and it depends on. The most important thing is to consult and discuss with oncology team, and say, this is what I'm planning to give. How much steroid should we give? What will the patient tolerate? Because it depends on what other chemotherapy they are getting. What are the other blood marker levels, what is the hematological numbers, and so forth. So it's kind of a difficult situation, and it's hard for me to give one dose of steroids. So it's a very high dose of steroids, that's all I can say. And then the main thing is to discuss with oncology and tailor it and personalize it to that particular patient based on what kind of symptoms they're having, what other chemotherapy agents they are on, what are the other numbers looking like? And the second part of question, can you repeat it, Dr. Mehta?
Yeah, just how do you decide on the duration of treatment?
So again, it's very patient specific. In this lady, I believe she received the treatment for about 2 days. And we tapered the steroid for a long time, for about, I believe, for 2 to 3 weeks, she received oral steroid tapering. So again, there is no recommendation or guidelines on these patients, unfortunately, right now. Very personalized management. And in this lady, I remember that when we started to taper her steroids, she started to have a little bit of chest pain again. She was still wearing life vest, so we again had to go up on the steroids and taper it again for 2 to 3 weeks. So she was on a steroid dosage for a very long time.
So do you use troponins to help guide when to stop steroid treatment? Dr. Gongora says that she had a patient who ended up receiving steroids for a week or so, but it was difficult trying to figure out when to stop and the treatment.
The main issue is that the troponin, if the steroid is started early and it's the patient is responding, the troponin starts to come down within very quickly. So you will see a response within 1 to 2 days, or even within a day that troponins have started trend down. But remember the slide I showed with multiple lymphocytic infiltration of the myocardium. So there's just a lot of inflammation going on. It takes a while for the complete resolution of myocarditis. And again, in some patients, it may be different. So this patient, like I presented, had chronically just symptoms every time we started to decrease the steroids or decrease it very low, even outpatient, she would have symptoms. And because of her BT, I would again get concerned and put her back on a higher dose of steroids and then again taper it. So you would see a little bit of troponin. Troponin can help guide, but I think the main thing is to see how these patients respond clinically, and then based on that, guide the steroid management. And of course, we'll talk to the oncology the entire time, because there are certain conditions where steroids may be actually detrimental to their cancer. So it's just it's a tough spot to be in.
Okay, does anybody else have any questions? Okay, we will end grand rounds here then. Thanks so much, everybody.
Thank you so much.
The preceding program is copyrighted by Emory University.